Okay, Chair, you're live on YouTube whenever you're ready.
Right, thank you. Thank you, Scott. Welcome everybody to the Health Scrutiny panel. I think the date today is the 4th or the 5th of April. I'm not sure where I am this week, to be quite honest. The meeting is being virtually streamed via the Council's YouTube channel, and whilst members of the public can view the meeting, they will not be able to actively participate or comment on proceedings. As the meeting is being live streamed, I would remind all participants that their conduct should reflect this. Normal rules of procedure applying with any questions or comments directed through the chair. I'm Dorothy Davison. Could we start with apologies for absence, please?
Yes, Chair, I have apologies from Councillor Rooney.
Right, thank you for that. Agenda item number 2, which is, have we any declarations of interest? No, thank you very much. Agenda item number 3, which is the minutes of the last meeting. Can we agree these minutes, please? Philippa, yes? Thank you. Thank you very much for that. Have we got a seconder? Thank you. Thank you, Councillor Halawi. Right, we go on to agenda item number 4, which is Carolyn is going to give us an update on the health and care bill. It's impact and health scrutiny. Is that right, Carolyn?
Yes, that's right. Thank you, Chair. I've got a short presentation. If you're happy for me to bring that up on the screen, I'll just bring that up now, if that's okay.
Thank you. Welcome, Councillor Mawson.
Okay, can everyone see that? I'm not sure.
Yes.
Yes. Okay. Well, I'll just quickly run through the presentation, Chair, then take any questions at the end if that's okay. But obviously, if anyone's got any questions at the beginning during the presentation, I'm happy to take those as well, as however you prefer, Chair.
Whatever would you prefer?
I'd probably prefer.
I think we'll do them at the end. I think we'll do them at the end, Carolyn.
Hopefully, I've answered all the questions. But if not, then obviously we can have a chat about those.
Yes,
so,
thank you.
Okay. So. Obviously, the Health and Social Care Bill is going through Parliament at the moment, and there will be some changes and implications for health scrutiny as a result of that. So on the 11th of March, there was a Scrutiny Officers Network meeting, a meeting of the National Scrutiny Officers Network. And in attendance at that meeting were representatives from the Department of Health and Social Care and some representatives, including the Chief Executive of the Centre for Public Governance and Scrutiny. So at that meeting, one of the agenda items was on the health and care bill, and I just thought it would be helpful to update the panel today on what happened at that meeting and what some of the changes will mean for scrutiny and health scrutiny locally. So we know that there's going to be certain changes to the reconfigurations process that have been proposed under the health and care bill. So whereby currently, if there's a reconfiguration and it's a substantial variation to service provision, then the health service has a duty to consult with health scrutiny, and as part of that consultation process, if the scrutiny panel aren't happy, they can make a formal referral to the Secretary of State, which is a power that we've only used on a couple of occasions, I think, and it's not something that's used regularly. But the changes will mean that that power no longer exists in the current format, and it will be changed slightly. So what will happen instead, it will be the Secretary of State that calls a decision in as opposed to the Health Scrutiny Board that calls the decision in. And so the Department of Health and Social Care have advised that they're going to be issuing guidance to outline how that calling process will work once the bill that goes through Parliament. But sitting alongside that, what they've also produced is a draft scrutiny principle document. So then the aim of that document is to help reinforce the importance of health overview and scrutiny as we move to statutory integrated care systems, which is obviously a key feature of the Health and Social Care Bill, and also to explain how the health overview and scrutiny committees will relate to the new system, because obviously it's going to be quite different. So what they explained was that the implementation of the bill is going to be phased. And so what's going to happen in respect of the new reconfiguration power, it'll have its own separate guidance and engagement, but it won't start at the same time as the statutory integrated care systems. Initially, the statutory integrated care systems were meant to come on board April this year, but that was then delayed till July of this year, but they are in kind of a shadow form set up at the moment. So as of July this year, they will come in statutory integrated care systems. However, the element of the reconfiguration power won't start off in July of this year in the way that the integrated care systems do. The current system of our power to make a formal referral to the Secretary of State will remain in place for probably approximately a year. They haven't got a definite timetable at the moment, but they think it might be for about a year. So there were 80 participants in attendance at the National Scrutiny Officers Network, including 12 health scrutiny chairs. And so the real aim of the meeting was for the Department of Health and Social Care to share some of the ideas they've got about what they're going to put in this guidance document, and for members to comment and officers to comment on some of the principles that which this document's going to contain, that they're going to publish to ensure that the role of health scrutiny is fully effective in integrated care systems. So one of the emphasis from the document is that leaders from across health and social care should work cooperatively with openness and honesty to ensure that ICSs understand the importance of health overview and scrutiny in creating better outcomes for patients and service users, and ensure that ICSs are accountable to local communities. Inevitably, the design of new models of integrated care and support that have been introduced through the Health and Care Bill will inevitably lead to changes in how and where services are provided, and therefore scrutiny still has a key role to play in that, and the benefits of scrutiny and involving scrutiny in that process and allowing scrutiny to contribute and represent the views of the particularly local communities still has a valuable role to play. So the intention from the Department of Health and Social Care is to publish this scrutiny principle document in the summer, and obviously that copy of that document will go to leaders within the health and social care systems. And so there's some key principles that they've focused on within that, which they're asking health and social care leaders to observe. So there's 5 key principles as it stands at the moment in draft format, that the way in which the ICSs work with us needs to be outcome focused, balanced, inclusive, collaborative and evidence-based. So one of the key roles of the integrated care system is, the integrated care board, is to produce a forward plan, and then for the integrated care partnerships to form their own strategies. And so in terms of how the Department of Health and Social Care sees scrutiny's role in this, there needs to be some thought given to how we would consider those strategies. Also, if ICSs are going to be undertaking reconfigurations, they need to share those proposals at an early stage with us in the same way that they do now. And again, it points out that there should be a distinction drawn between informal discussions and formal consultations, which in a way is quite similar to what happens now, because sometimes we will get advised informally that they're coming up with some proposals about certain services before they actually go ahead and launch a formal consultation. Other times it'll just be at the start of a formal consultation, we'll get informed that that's happening depending on the degree of reconfiguration that's taken place. It's emphasised that about inclusiveness, that engaging with scrutiny is also a way for ICSs to add richness to their understanding of local need and a way to connect strategic planning at system level to the nuances of local pressures and requirements. I think there's a real emphasis there that the role that health scrutiny has played in reconfigurations does add value and gives elected members and provides democratic accountability really for members to voice the concerns of local communities and bring that to the table, and for the people who are proposing the changes to really get a thorough understanding of that in a different way to what they may gain from a formal consultation exercise. Collaborative under the new ICS's health scrutiny may increasingly need to cover issues that cut across local authority boundaries. Obviously, the idea with the integrated care system and the integrated care partnerships is that some of the things will work at a bigger level in some respects, at a system level, on an integrated care system level, and a partnership level, on a Tees Valley level. We're quite fortunate on that in the Tees Valley in terms of scrutiny, because we already have set up a Tees Valley Joint Health Scrutiny Committee, which fits quite nicely with the new proposed integrated care partnership. And that committee or joint committee has been in place for a number of years and works very well. So we kind of have that there already, that the integrated care partnership could use as a form of key engagement in that. And then evidence-based ICSs should have plans and protocols in place for sharing information for the purpose of scrutiny, as this will avoid the need for continual ad hoc decision-making when information is requested. So in terms of the feedback that was given from the officers and members that were in attendance at that meeting, they advised the Department of Health and Social Care that they felt that practical examples of what good practice look like should be included. It should then make sure that the language used in the principal document is fully understood, that there should be minimum standards for working arrangements, including papers for ICBs and ICPs have to be published at least 5 clear working days before meetings being made available to the public and press, and provision for the public to ask questions. In some areas, they didn't necessarily have joint health scrutiny committee arrangements set up in a way that reflected the new integrated care partnerships or integrated care systems, and so that there would need to be consideration about that being established on a more permanent basis. Some people felt that there needed to be greater clarification as to the role of the health and wellbeing boards within the new system. And then there was also reference made to a diagram which shows the delivery structures or partners and bodies required, similar to that produced by the King's Fund. So I'll just show this diagram, which is, so the King's Fund are a health policy think tank who produce a lot of very well researched papers and on different health, on the health sector generally, and different things that are happening. They've also recently produced something about integrated care systems, and as part of that document, as part of that read, they have included this diagram, which is, I suppose, being referred to as the most comprehensive or straightforward diagram to describe how the integrated care partnerships and integrated care board will work in the future, as well as the different geographical footprints which are often talked about in relation to it. For example, you'll often hear people say system, place, neighbourhood, and what level we're working at, whether we're working at a neighbourhood level, a place level, or a system level. And so it obviously shows you in that diagram that the statutory ICS will be made up of the Integrated Care Board and the Integrated Care Partnership, but then sitting underneath that will be the place, which is the place, the emphasis on place is really about local authority, upper local authority tier level. So Darlington, Hartlepool, our own local authorities will be the place level on that. The system level will be the Northeast and North Cumbria ICS, so the system level on that, and then the neighbourhood level tends to be predominantly focused around the general practices and the primary care networks, etc. But some of the members commented that although obviously the Care Quality Commission's at the top there and NHS England are at the top there, there's no mention of scrutiny within that document, within that diagram at any point. So I think there are still questions from scrutiny's perspective of where they fit within the new arrangements. And that was everything in terms of the presentation. So I'm happy to take any questions, Chair, and I hope that helped to explain a little bit about what might be happening.
Thank you for that. Very informative, Carolyn. Thank you very much.
I'll just try and stop sharing it. Sorry, 2 seconds.
Is there anybody who would like to ask a question? Alma?
Thank you, Chair. Caroline, I'm very concerned is probably the word. Looking at the principles, my immediate concerns were actually reflected in the feedback that you also showed us. I was relieved that other people probably had the same impression as I did, that really this, to many people who haven't got a background in the health system structure and changes that have been over recent years, probably be daunted by all this fundamental change. I'm concerned about the language, but that was mentioned in the second feedback concern, that the language used in the principles and the expression of intent should be absolutely crystal clear. And like you showed us in the diagram, we need diagrams of such clarity and inclusivity that people will be able to understand the process of this massive change. I just feel that sometimes these documents, and including the principles, are written for an audience that already has inside views, and that's probably okay to a certain extent, but I think it should also be comprehensible to people that aren't so well versed in the ins and outs of what it used to be like before and where we're going now, because it's difficult to scrutinize for anyone, including health scrutiny panels, systems that are not clear in terms of where it was and where we're going and where's the gaps and where's the issues. So, you know, the diagram you showed us proved that they'd already omitted to put in health scrutiny. So I am really concerned about fundamental issues of clarity of communication. And if I were writing such a document, one of my key principles would be that clear communication was apparent at all stages, at all times, to all concerned and interested parties. And I know it mentions inclusivity and collaboration, and you could say that's underwritten in that. It's between the lines. But I think I would recommend a key principle, never mind the feedback on the principle, a key principle should be that communication and clarity and expression and description of the changes should be very much at the forefront of the writer's mind at all times. Thank you.
Thanks,
Thank you
Anna.
for that, Councillor Lawawi. I totally agree with you. Some of it is totally that people just would not understand exactly what's going to happen, and I think it needs to be made more clearer to anybody out there so that they understand. Otherwise, they'll just go along with it and not understand it totally.
And
Is
when
there
you think,
anybody?
Chair, from our point of view, you know, if somebody says to us, one of our residents, oh, can you explain
Yeah.
to me the changes then that's happening in health now and how are they all fitting and how do we fit it? I mean, honestly, to try and explain that to a resident or someone, I'd need a crib sheet. I'd think, oh, I can't answer that right now. I'll have to go consult and rewrite something. You know what I mean? And that's the position we're in. People are entitled to say to us, oh, you're on our health scrutiny panel. What do you know about all these changes in health? Where do you think that's going to leave us? Where is this going to benefit me? How is this going to help progress any particular situation that the resident is aware of? And that's what we have to do at grassroots level.
Yep.
And that's why I think it's key that the clarity of this is apparent for all of us so that we can convey the messages in a cascading method down the line to anyone out there who asks us all about it. Because at the moment, I don't feel I could explain all this to folks in a way that's probably reliable. I'd have to say, I'll see you next week after I've read about it and brushed up on it and understood a bit more and all the rest of it. I don't know how other people feel. Is it just me feeling, and I'm aware of this has been going on for a while and I've been aware of the progress, as Caroline knows, we've had many discussions about this. But still, I think, well, how do I explain this to the person on the street who just happens to stop me for a quick update?
Thank you. Anybody else? Councillor Morstan?
Thank you, Dorothy. Alma's right. There's a lot of detail. Might be being cynical, but it looks like being written by healthcare professionals, for the benefit of healthcare professionals. It's unbelievable. The one thing that leapt out at me that I like was that it's to reinforce the importance of health scrutiny and ensure that the role of health scrutiny is fully effective. Really, that can refer to any area of scrutiny that this council carries out. We're all aware of an attempt at the council meeting to eliminate some scrutiny, take away some scrutiny powers from us. So that bit I'll say well done, but the rest is pretty complicated. Thanks, Chair.
Thank you. Craig?
Thanks, Chair. You know, I can only take on board what the committee's has said and the way that you've perceived the information that's being shared. I think what I would try and stress is that the part of the NHS that most people come into contact with, so the delivery arm of the NHS, the hospitals, the GP practices, that's not changing. So this predominantly affects the governance and the oversight of the NHS and the planning functions, which obviously scrutiny does come into contact with routinely. Just from a perspective of the local NHS and the Tees Valley in particular, you know, we've always had a really good relationship with scrutiny. We've always found the input from scrutiny really valuable whenever we've been going through any service transformations, redesign programs, etc. And that's a relationship that we'd really look to continue to build on over the coming years, and certainly as we transition from a clinical commissioning group into the local arm or the local representation of the Integrated Care Board. But that's certainly feedback, or the feedback today I'll certainly take back into the clinical commissioning group and try and influence the way we transition across from one organisation to another.
Right, thank you for that, Craig. Carolyn?
Thanks, Chair. I just wanted to kind of, I suppose, make reference to the fact that the health system's always been very complex. all the time, and our involvement in health scrutiny, it isn't a case that you can just explain it on the back of a postage stamp, because there are so many different elements and there are so many different factors that you are absolutely right that most people wouldn't understand or even begin to understand the different roles that different organisations play. And at the end of the day, the part that people are bothered about is the delivery arm, as Craig's made reference to, our actual James Cook Hospital, or the service that people receive at the Live Well Centre, or the service people receive from their GP or other service areas. And the parts about the reconfigurations and the trusts and the setup behind that, the mental health trusts and the acute trusts, I think you all actually know quite a lot about all of those things, and I know you might feel as though you wouldn't be able to articulate that, or maybe not know it inside out in the way that certain health professionals would. I think you would know a lot more than the average person on the street would know about how that all fits together, and about some of the ways in which that is going to change in terms of the commissioning arrangements. And I think that's the part of the key difference in terms of what's going to happen if we can get across a message that you can take away with you, is that the way in which the services are going to be commissioned might be going to change, but the potentially benefits in that, and that's the purpose of going to a different model, I guess. And it will be up to us as Scrutiny still to be involved on a similar level to what we've been involved previously. However, it's just that some of the powers that we used to have previously have also changed, so we won't have the same power of referral in the way that we did have. Well, we will have for a little while longer yet, so it won't fall in line exactly with the integrated care systems being introduced. It might be about a year's time before that goes completely, and I don't think it's all been formally finalised yet in terms of what's going to happen. I think they were originally, the proposal was originally that what we used to use as the independent reconfiguration panel would go completely. But I think that is going to stay in place now and still provide advice to the Secretary of State, because obviously there are concerns that he's going to be involved in a lot more reconfigurations than he would be currently if he's involved in all of them, if that makes sense, rather than ones that are just formally referred to him. So I think, yeah, so it was just to try and hopefully reassure you a little bit that although it is really complicated and maybe it hasn't been written, I hope the document when it does come out is very, I'm sure it will be very straightforward, but it's not an easy thing to explain, if that makes sense. I think they've got a hard job trying to make it easy to explain. Chair.
Thank you, Carolyn. You did a good job, actually. Councillor Halawi?
Thank you, Chair. Yes, I think you're right, Caroline, and I take on board everything that you say, and I appreciate the complexity of it at all different levels. But I think it's important, really, for health scrutiny panels to know exactly where their powers were before and their input and influence was, and exactly where it is and can be now. And if there are any changes, subtle or even more substantial, that's where we need to be able to see where we stand in the future, as you say, whether referrals and things can still be possible. So for health scrutiny panels, we need to clearly have a list. You know, it seems to me that I would like to see exactly on one side, this is the powers that health scrutiny panels had, and this is the powers that are anticipated that they will have in the future, and the differences in that subtlety. And the other key thing for us to know all the time is the funding mechanisms. You know, to what extent is the funding there, and will it be shifted, and where will it go, and where will it be reduced, and where the funding's coming from? Is there a move to more privatisation? Is there a move to more substantial funding from central government? And it's those sort of questions, isn't it, that we really need to be aware of all the time. And it's through this consultation and proposal period and sharing that we need to be able to know which questions exactly we need to ask of whom and when.
Thank you for that, Councillor Halawi. Is there anybody else who'd like to come in? Carolyn?
Yeah, sorry, it's just to come back on that, Chair, to say obviously within the Health and Social Care Bill, it is quite clear that the power of referral, the Secretary of State, is to be removed from the health scrutiny function. So that there has been to and fro on that. It has been bounced back a bit in between the Lords and the Commons at the committee stage. So it has been added in and then taken out and added back in and taken out, but the Secretary of State is quite clear that the intention is for that power to be removed. So we'll no longer have the Secretary of State referral power not once it comes in immediately, because there's going to be a little bit of delay in the process. So it might take up to about a year, and that's why they're issuing some guidance documents to go alongside it. But again, the documents that are going to be the principles, scrutiny principles, effectively, it will be a guidance document. It won't be regulatory. So whereby we would have had regulations previously in respect of scrutiny, it isn't legally binding in that way. It's guidance as opposed to regulations. So the influence that we have will change. And obviously from a scrutiny perspective, we've argued strongly that we think that power should have been kept, and we should have always kept that power.
Absolutely.
That argument has kind of been lost, if that makes sense.
And that's
yes,
really
and that's not something that can be changed. That's what's come down from central government. So it's kind of the guidance documents that are being produced that will sit alongside the new health and social care bill are the best hope of ensuring that scrutiny still has an important role to play and is acknowledged in the sense that it does bring a different dimension to the table in terms of local discussions around potentially reconfigurations, which are possibly more likely to happen as a result of the new setup and new arrangements.
Thank you, Carol.
Thanks, Chair. Yeah.
Chair, could I just say that I think that is so important to have lost that power. I mean, I know you might say, Caroline, it's a done deed now and it's gone backwards and forwards, but to me, that's so fundamental to take away that right that we have to make referrals on issues that are rare, but so terribly serious. And as Caroline knows, this health scrutiny panel in recent years has had referrals to the Secretary of State, and massive change and improvement has come as a result of that. So to lose that power, to me, is fundamentally a flawed arrangement, and a very, very sad one as well for democracy, that we've lost that chance to make our voice heard.
I'm sure we'll keep our eye on all this, because we do need to have our voice heard. Carolyn, would you like to come in again?
Yeah, so just to say that
Then we'll move on.
Yeah, that's hopefully the guidance document around our engagement in the future with the new ICSs and new integrated care partnerships. And as Craig's already said, we've always had a good relationship, so there's no reason why that should change. The people who are involved in the integrated care partnership are going to be the same people that have been involved in the Tees Valley CCG. The people are the same, it's just the organisation and the governance arrangements that are changing, and I'm sure will still be the same level of commitment to having everyone involved at the table as there has been always. Thanks, Chair.
Right, thank you for that very much. Can we move on now? Did anybody else want to add anything? No, thank you. Can we move on now to agenda item number 5, which is regional health update? Are you giving in that, Caroline, or is it Mark?
Yeah, I'm happy to give a regional health scrutiny update. It was just to update on a couple of things. The first thing was we had a Tees Valley Joint Health Scrutiny Committee recently, which there was quite a few items on the agenda at that meeting in terms of, I'm sure members will be aware that Tees Esconway Valley's NHS Foundation Trust had some negative feedback from the CQC at its recent inspection report, which was published in December. Subsequently, Stockton Borough Council, a full motion went to their council to call for a public inquiry, which was approved. But as part of that, it was delegated to a decision by either the Tees Valley Joint Health Scrutiny Committee or their equivalent health scrutiny panel at Stockton Borough Council to determine whether that went ahead and whether a formal letter was written to the Secretary of State to request a public inquiry. So in terms of the Tees Valley Joint Health Scrutiny Committee, they had representatives from TUV there in attendance, as well as the lead inspector for the CQC was also in attendance to give them the Tees Valley Joint Health Scrutiny Committee the opportunity to hear sort of from both parties really in terms of the work that TUV have been undertaking to make the necessary improvements, because there had been some statutory notices issued and which they'd been asked by the Care Quality Commission to improve upon by, I think the deadline was the 1st of March. I think the meeting was about the 18th of March. So obviously that deadline had passed, and the CQC provided positive feedback on that, and were happy with the work and the progress that they'd been advised that was being made. However, the CQC did also advise that they couldn't really, without actually going in and doing an inspection themselves, again, a full inspection, then they couldn't guarantee that things had improved, because the only way in which they can do that is actually by doing a physical inspection, but that there would be an inspection, a re-inspection very soon. And to date, they were satisfied with what information was being provided to them. Obviously, the Chief Executive of CHUV was there in attendance, as was the chair of the board at CHUV, and one of the director of communications. They gave a very comprehensive presentation about what's being done, the different, how they've changed the whole makeup of the board, the number of additional people that they've employed, how even against the backdrop of COVID and number of employees going down in most sectors, that they managed to recruit, and they painted a relatively positive picture, I guess, of how things were progressing. The members were still quite concerned. The Tees Valley Joint Health Committee members were quite concerned, and Paul Murphy, who was the chair, offered the opportunity for the Tees Valley board to actually go and visit Rosebery Park and visit some of the wards, meet some of the staff, talk to some of the patients, because they felt happy and confident that the panel was very welcome to attend. And so members were quite happy with that and decided that they would take up that opportunity. And so it's anticipated that that visit will now take place on the 11th of June. And so there'll be representatives there from all of the different 5 local authorities in attendance, and we'll have the opportunity to spend some time with some of the staff and see some of the wards themselves. So that was just a bit of an update in terms of CHUV. However, subsequent to that, they have a combined adult social care and health panel at Stockton, and they determined that they wanted to make a formal not a formal referral intent, but to write and call for a public inquiry. So Stockton Borough Council have still gone ahead and done that from Stockton Borough Council's point of view. So it was just to update our committee on that. NIAS were there, North East Ambulance Service. They provided a very comprehensive update on all of their performance. We're very fortunate in the North East because we have one of the best performing ambulance services in the country. They always come out top on the stats, very near the top. They did explain about some of the issues that they are having, but overall, given COVID and given everything else and the new changes to the times that are now measured and how it's measured differently, they were performing exceptionally well. So I think that was a positive news story on that side. In terms of opioid, I know that the panel looked at this issue previously, and there was an update given in terms of prescriptions, and they've done remarkably well on reducing high-level dependency on opioids, and there've been work done across practices across the Tees Valley, and the figures were really good for that. And we're also progressing in respect of the learning disabilities unit and some of the changes that have been made there because of some things that were highlighted in relation to the way in which the wards were separated for single sex. So they're going to have to make some changes, but they're on with that, and they said that they would keep us informed on that. So that was just to update everybody on what's happened at the Tees Valley Joint Health Scrutiny. Thanks, Chair.
Thank you for that, Carolyn. Councillor Halawi, is there anything you would like to add as chair of that scrutiny panel?
Chair, thank you for the opportunity to speak. I agree with everything that Caroline said. That's the discussion that we've had, and it was a really interesting, quite a powerful meeting. There were some very in-depth questions. It was a very informative meeting. And then, as Caroline said, we subsequently had a small group meeting where we decided that we will go and visit on the 11th, and we'll see the operation of the system in place at Rosebery Park, and we'll meet with people. So I think we've made fantastic progress in trying to understand what's happening and to understand the points of view of all the different participants. So it really was a good meeting, wasn't it, Caroline? And I think that we got a lot out of it, and we know where we're going in the future. And in terms of the handover of the responsibility of the chair, I've been chair for the last year. The next area to be chair is Darlington, and we've been working together with the Darlington soon to be chair. and she's fully au fait with exactly where we are. So we're looking for a very smooth transition across the arrangements, across the scrutiny, across the topics and where we look at things from this year into next year. So I think that's quite key as well, isn't it, Caroline, that we're looking to move things on, that there will be a real smooth transition and that the communication across the whole of the Tees Valley will be very clear and transparent at all times. So with lots of feedback and lots of activity. Thank you, Chair.
Thank you, Councillor Lowy. I must admit I attended that meeting myself as well and found it very informative, and it's nice to think that you've been invited for a visit, although the CCG will have been in again, I presume, before the attendance of anybody from the scrutiny panel. Would that be correct, Carolyn?
We don't know when they're going, because obviously it's an unannounced visit. So I think that they usually visit within 6 months of the last report being issued. And obviously the report was issued in December, so I'd anticipate by July, but it just depends on when they actually have it scheduled. Will not be advised of that, Chair, because it's unannounced.
Okay, thank you very much for that. Is there anybody else would like to add anything? Right, thank you. Thank you for that today. You've done really well, Carolyn. Thank you very much. Can we move on to agenda item number 6, and we welcome Mark Adams, Director of Public Health, to give us an update on COVID-19 and local public health and NHS responses, please.
Okay, thanks, Dorothy. I'll just share, if I can remember how you do this. I'm going to end up sharing the wrong thing here, I think, aren't I? Second, let me just cancel that. Sorry, I'll share. Because I've got 2 presentations open. I need to close one. Right, try again. Oh, I think that's sharing now, is it? Is that sharing? Sorry, I can't.
It is.
Yes, Mark,
Yeah.
thank you.
Yes,
It is.
it's
Thank
sharing.
you.
Thank you. Right. Okay. I'll rattle through this quite quickly because we're shifting into the living with COVID stuff. So I've got some figures in terms of our current position, and then the kind of national guidance about the move to living with COVID, and I guess some of the outstanding issues that leaves us with. So you can see the rates nationally from Plymouth at over 1,000 per 100,000 down to Middlesbrough at 579 per 100,000 up to the 2nd of April in terms of cases within our communities. The testing by specimen date, you can see dropping off as the testing availability diminishes, so that'll fall substantially, and I've got some details in terms of what testing remains on a future slide. So essentially we won't really know what the picture in the community is for COVID, and that's basically part of the national strategy to move to living with COVID, as focusing on symptoms and people that are ill, isolating where they can, rather than charting the case rates and so on. Our rates are flattening off and will fall off a cliff as the testing disappears, but we're still at higher rates as we are across the country. And the ONS surveys demonstrate that there's more people infected now than at any previous time in the pandemic, I think was the recent headline. Same with the age rates as well, quite high rates for 60 plus, and we are seeing more cases in care homes where there is still testing, although not significant illness in the same way that we did before as a result of the high rates of vaccination in that age group. South Tees at the peak had, or the most recent peak, had 176 COVID patients in. There's 142 now. We don't have the breakdown nationally. They do a breakdown of in because of COVID and in with COVID being about 50-50 nationally. So some of those people will have tested positive but are in for other reasons, and well, around half of them will have tested positive in for other reasons, and around half will be in because of being ill as a result of COVID. But the translation to critical care, we've got 2 people in critical care, is lower than we were seeing previously. So the people that are ill are less ill than they were in previous waves is certainly true. Mortality, there are still people with COVID detailed on the death certificate, but at relatively low numbers compared to previous peaks that we've seen. In terms of the vaccination uptake, Middlesbrough is relatively low, which reflects the demography in terms of deprivation and BAME population. Those 2 things kind of combine to make it more likely that the vaccination rate is going to be low. And you can see the kind of social profiling of the areas that have got higher vaccination rates, generally being more wealthy areas. So in the northeast, Northumberland has been the highest all the way through, as getting to the vaccination site, being able to free the time to go, not reliant on sort of late shifts and so on, play through that. So 77% of eligible have had the first dose in Middlesbrough. 71% of everybody have had the second dose as well. And then of those that have had the second dose means that we could only get 71% at this figure, but we've got 52% of everybody has had the booster. So not as good, obviously, as some of these other areas, but actually, given some of the backlying, the underlying constraints that we have, I think a relatively good position for Middlesbrough to be in. I won't go through that, I don't think. So in terms of living with COVID, we've basically been through most of this. Testing students in the education setting was stopped on the 21st of February. Legal requirement to isolate was stopped on the 24th of February, although the guidance was to isolate and do the 5 and 6 day test to release. But the sort of messaging was more around, I guess, was less directive than that. So the guidance was isolate if you're positive, but the messaging was that we're moving to living with COVID, and the previous restrictions were being lifted. End of self-isolation support payments, I think, is important, and a change in the nature of how COVID isn't a specific thing to detail on sick pay and sick certificates anymore. So basically, they've also, at the same time as testing has ended, they've put out more symptoms of COVID as we move through the Omicron and the BA2 subvariant. So there's more symptoms over and above the continuous cough, temperature, loss of smell or taste, to include these other ones: tiredness, shortness of breath, diarrhea, vomiting, and so on. And looking to manage COVID within an overall kind of management of respiratory infections, and actually putting the emphasis on symptomatic. So if you're poorly, stay at home, as we'll see in a slide to come. So the testing will be much more difficult to come by, but those who have tested positive, there's a differentiation between over 18s. The advice is to try to stay at home and avoid contact with other people for 5 days after the day of the positive test, and under 18s is to stay at home. Try to stay at home for 3 days, and apparently there is an evidence base behind why over 18s is 5 and under 18s is 3, based on their likelihood of infecting other people. But I haven't seen that guidance, and last time I spoke to them, neither of the regional health protection team, but that apparently it is based on evidence base. So the testing that does exist, particularly around symptomatic testing, is sort of split in this test to care, test to treat, test to protect model. So obviously a much smaller proportion of the population than the previous testing regime, where it was much more freely available. So test to care is those in hospital where understanding as in any sort of testing, understanding it's COVID obviously affects the treatment that and the care that people will receive. Test to treat is those that are clinically extremely vulnerable, who will have had PCR tests sent out to them, and if they get symptoms, test positive, then they get onto the antivirals to prevent them becoming seriously ill from COVID, and then tests to protect in high-risk settings like adult social care, NHS, prisons, and those settings where risk of infection is significantly higher than other settings. The asymptomatic testing is restricted to patient-facing NHS and NHS commissioned independent healthcare providers, staff in hospices. So basically those settings where people are dealing with vulnerable people, to try to reduce the potential for basically staff infecting vulnerable people in those settings. Care home visitors, the testing requirement is limited to those that provide personal care. So there's a potential risk there of people bringing COVID into that setting. And again, prisons, which we don't have on our patch, but obviously we do have people from Middlesbrough that will be either in prison or working in prisons. Testing for SEND and care home staff during an outbreak will be provided, and a lot of the outbreak management will be more centralised than it's been throughout the pandemic thus far, and the local role will kind of unfold as the outbreak unfolds in effect, but it'll be led by the regional team. COVID vaccination, as people know, it was extended over the weekend to 5 to 11, in addition to the 11 to 15 group, and so on as detailed there. So almost all over 5s can get vaccinated or a booster, and the spring booster has offered to those over 75 in care homes, and those 12 and over with a weakened immune system will have that spring booster. And I anticipate there'll be further booster programs which are likely to be delivered through community pharmacies and potentially GPs, although I think it's more likely to lean on community pharmacies to deliver that. So just in terms of our own sort of local consideration, the surveillance is significantly different to what it was before, because there's much less testing. So understanding new variants and acting will be very limited in effect to those that have tested and been sequenced in hospital, or the various sort of staff testing, symptomatic testing that we've seen through PCR, because you can't sequence lateral flow tests. Vaccination still critical, and the regional vaccination site at the Riverside is closing for a month, and we're working with them to understand what pop-ups we can develop in our communities, as you've seen throughout the vaccination program. So we're still getting relatively good numbers through the pop-ups that we're doing, so we're going to continue on with those to push vaccination. And I think we're probably seeing people attend as you're starting to hear more people be infected and be ill with it. So I think vaccination is probably coming up the agenda of those that either haven't been vaccinated or haven't seen the program through to its end point. The reduced surveillance, we're not really going to know when there are outbreaks unless the outbreaks are symptomatic and affect a lot of people. We're not going to know in the way that we have done when there was more testing available. But what we are trying to do is understand, do contingency planning. We're working across the northeast to understand what we are able to do at a local level to protect people, which is limited within the overall government guidance, and particularly things like encouraging safer behaviours through public health advice and local messaging. What we've found throughout is the national mood music trumps anything that we do locally. It's very difficult to cut through with specific local messaging, but we will continue to use our COVID champions and getting those sort of trusted voices in the community and understanding what the issues are within the communities. We're going to go through a process of learning lessons from the pandemic, and that'll translate into the work that we do moving forward as well, and understanding what, if anything, we can do around ventilation in local settings to reduce risk. So in effect, I guess in headline, there's very limited impact that we can have locally within that national guidance, but we're trying to work through across the northeast what we can possibly do and how we can use the lessons that we've learned to respond should we need to, if there are outbreaks, albeit that they'll be led through the regional team. And that is the end of that, I think. Yes. I'll try and stop sharing. Happy to take any
for
questions.
that, Mark. Thank you. Have we any questions? Can I go to Councillor Story first, please?
Thank you, Chair. I was just wondering if at the next meeting it might be possible to get some statistics on how many people have long COVID in our communities. Because obviously I know personally that there's a huge waiting list for the long COVID clinic. And I think it's really important if we can just see that as a scrutiny panel so we can go back to our communities and sort of find out how we can help. Thank you.
Yeah, certainly we can pull together what we have. I think it's a long COVID is it's still a little bit indistinct. I mean, we all know the kind of how it potentially presents itself, but we can pull together what we have to discuss here, certainly.
Thank you for that, Mark. Councillor Lawi.
Thank you, Chair. Thank you, Mark. It seems that since we're learning to live with COVID, that there's a reduction of support mechanisms right across the board in all ways possible, which will be a reduction in funding, obviously, to support people. So it seems to me now that, you know, it's more difficult to get the vaccinations, apart from pop-up clinics, which I very much support and have always been in favour of, but presumably they will become less and less frequent in different places. I'm sad to know that testing is now going to become payable. And did you say that COVID isn't any longer viable on a sickness absence form?
It's just not a specifically. You don't need to specifically detail it on a sickness form.
Okay.
So you can still be sick and get sick pay as a result of COVID, but it's just not a kind of recordable. You know, there's not a requirement to record it.
Okay, so that's a bit sad as well, because it means we're losing statistical data there potentially, but yes, okay. It seems that the requirement is not to self-isolate. There's not a requirement, it's more an encouragement. So, you know, if we are people in difficult financial circumstances and we only get paid when we go to work and then we have COVID, well, how are we going to manage to stay at home and not get paid? You know, because we're not breaking the law. So we're going to trundle off to work with our COVID. This new variant, as I understand it, is even more easily transmissible than other variants previously. And we don't know that the people we're going to be amongst are going to be more or less vulnerable. The chances are they'll be less vulnerable because the risks are, as you said, that statistically they're probably less likely to have been vaccinated. So all in all, it seems to me that our most financially deprived communities could be those that are going to be the most seriously affected by COVID in the future, and potentially quite seriously so. And I think that's a massive responsibility that the government is reneging on. And I'm really, really concerned about people in the more challenged financial circumstances. I know you can't answer that, Mark. You haven't got.
Yeah, I was just going to say, Councillor Lawi, that's a question that really Mark can't answer.
No, it's a comment that I'm making.
Yeah, it's a comment, but I don't want this meeting to become political, Councillor Lawi.
Well, inevitably it's political because the funding isn't there from the political party that has the funding in their hands. So that's
but this is a non-political meeting, Councillor Lawi.
No, it's not a non-political meeting in terms of discussing funding mechanisms that are in our communities or not.
Right, is there any more questions? Can I just ask a question, Mark? If an old people's home all of a sudden found that they had a pandemic within their little home, a lot of people with COVID, are you able to give them any help or any advice, or is that not possible now?
Yeah, that advice is through the regional health protection team, so through the UK Health Security Agency. So they are still working with care homes and sorting out the testing on day 2 and day 5 of the outbreak and all that sort of stuff, and will restrict visiting in the case of an outbreak. So there are some settings where we will know that there are people testing positive and so on. So care homes and NHS hospitals and so on are still more controlled, much in the way as they were before. It's kind of everywhere else that that isn't, but the regional health protection team is still doing that. there's a potential issue that if they get overloaded, which they have done before, and we've stepped in, because the funding has ended now, our ability to step in is less than it was before. But we'll do, as we have all the way through, we'll do whatever we can to support. We have made some of the infection control advice to care homes. I think that's been funded through the Better Care Fund for another year. So we've got additional support into care homes to improve or maintain their improved infection control regimes and so on. So there are specific settings that we're looking to do as much as we can to support.
Yes, because also, would this apply to a place of work?
Would what apply, testing or
Yeah,
outbreak?
well, if an office, say the council building was a lot of people, would we be able to go in and help them with advice, etc.?
The issue with that would be we wouldn't access to testing would be very limited if there was any access at all. So it would be more around advice from a kind of business contingency type perspective of what people might want to do, which would be back into if there's a workplace where there's a lot of people off sick, and you've seen with one of the airlines that they've cancelled flights and so on with people being off sick. The advice would be around shifting back to remote and so on, whilst to reduce the potential for people to mix. But it would be treated more like almost any outbreak or illness in that sort of setting, rather than specifically COVID. So most workplaces, it will be sort of pretty sort of generic advice along the lines that we've seen previously about keeping people safe. I don't think that the overall approach makes sense. I'm concerned about the testing from the perspective of understanding variants more than necessarily supporting a different way of managing. Because even if it wasn't COVID, but you've got a whole load of people ill with a flu type virus, the action would be very similar because the transmission routes are very similar for respiratory illnesses. So it does make sense, but there's an element of us sort of picking our way through at the moment, and I guess when the outbreaks will be based upon the symptoms rather than any sort of testing. But if I guess if we are able to support specific things that we perhaps don't know what they're going to be at the moment, then we will support them in the way that we have done throughout the pandemic.
Have you any information with regards to schools and the cases in schools?
There's no testing in schools, so
no
we
testing in
don't.
schools.
So again, that's based on symptoms, and if you're ill, stay at home. There's just that slight difference about staying at home for 3 days post symptoms compared to as an under 18-year-old compared to 5 days as an adult. But other than that, it's basically trying to look at what they call an all hazards approach. So looking at managing COVID as a respiratory illness in the same way as any other respiratory illness, really. And if you're poorly, don't go into work. I think I know you made the point about it being political. I do think that the try to stay at home, there is a social gradient of the ability of people to stay at home, which we've seen throughout the pandemic. That if
Absolutely, that's it.
I'm not trying to make a political point. This is the practicalities of it. If you're on a 0 hours contract and so on, then it's going to be more difficult to stay at home, which we have seen throughout, which does make Middlesbrough more vulnerable than somewhere, I don't know, Surrey or somewhere more affluent.
But
I've
I've got to agree with you on that. Yes.
That's what I meant.
Our ability to do anything about that outside of doing what we're doing around trying to encourage the vaccine uptake in those areas, it's pretty much limited to that, really, and the messaging we're doing through the community champions. Anything outside that is really limited, I think.
Thank you. Also, are we still, as a council, going to encourage people to have the vaccine?
Yeah, oh, definitely. Yes, yeah. I was just talking with Idris Rashid, who runs our BME network, about how we promote that through. There's a number of sort of magazines and so on coming out that we need to promote different routes to different populations that we know are under vaccinated compared to others. So it's specific geographies in the town, specific ethnicities and different groups that have got lower uptake than other rates. We've been doing that for the past year or so, if not longer, and we'll continue to do that to target where we know the uptake's lower. Because I think, in effect, the risk, whilst the protect bit is around clinically extremely vulnerable, those that are unvaccinated, are particularly older people that are unvaccinated, are at risk as well. So we'll continue to do that. I think the issue is that it gets harder to cut through the more we go on, and the more people carry on and living with COVID becomes forgetting about COVID. It makes it a little bit more difficult to get that message through.
Yes, right. Do you think, actually, Mark, that the uptake for 5 to 12-year-olds will people take it up? Is there much information out there to give people on how it's working for the 5 to 12-year-olds?
I think the most difficult group we've seen so far has been the 12 to 15-year-olds. So I anticipate the 5 to 11s will be a similarly difficult group to get through. What we've seen throughout is as you get through to the younger age groups, the perceived personal risk becomes less, and I guess the parents acting on behalf of their children will need to make some of those decisions. I don't anticipate a big uptake in that group, and of course the critical issue with that is protecting them, and also the potential to affect other people that might be more at risk. So we've seen the uptake of the school program, particularly in Middlesbrough, has been very low, although that has been supplemented by people being vaccinated at other sites where you can take 12 to 15-year-olds. So I think the 5 to 11s is going to be pretty tricky to get the rates high.
Right, thank you. Is there anybody else would like to add anything? No? Oh, yes. Craig?
Thanks, Chair. Could I just highlight some of the work that's been undertaken with our local acute hospital, James Cook, with the work that they've undertaken to maintain a full elective and outpatient programme over recent months. That's allowed us to reduce the longest waiting times within the hospital and got them into a really strong position in terms of their elective recovery, bringing the backlogs down. So we've got a really positive position in terms of where the North East and certainly where the national position is now. We have no 104-week waiters, and that at the moment, although that sounds like a horrendous position to wait 104 weeks, we don't have anybody waiting that long in Teesside now. So we've been able to get the waiting times down back below that. The only time any patient would wait that long now would be if they'd had COVID and were unable to come in and have an elective intervention. And there are specific rules in place around how long you have to wait once you've had COVID before you can call in. But a great achievement from James Cook to actually recover some of their waiting times over the period, even though we're still seeing significant community infection rates, and that's something that's been impacted right across the health system in the Tees Valley. Health staff aren't immune to COVID, so health services are continuing to be delivered while staff sickness is relatively high in comparison to how it would normally run. So just probably worth noting that, and like I say, some of the good work that's been ongoing with some of the provider organisations.
Yes, as a committee, Craig would like to say thanks to everybody, and also you, Mark, all your team, for all the hard work they've put in recently and over the last 2 years. It's been absolutely amazing. They've done so well. So thank them all for that, if you would, Craig, from our panel.
Yeah, we'll pass that on. Thank you, Chair.
Thank you. Right, thank you, everybody. Now, Carolyn, I believe you wanted to come in and give another little update on something. I'm not sure what it was.
Dorothy, I was just to provide an update on the Tees Valley Health Summit that took place last week. I know obviously you were in attendance at that, so it was just to provide an update to the rest of the committee in respect of that. I don't know whether you're happy for me to share a few slides on that. I'll just go through it quickly. Is that okay, Chair?
Yes, that's
Yes.
yes.
Sorry, 2 seconds. I'll just bring it up.
If it's okay with everybody else, there's nobody rushing off.
Can you see that yet, Chair?
Yes, yes.
Right, slideshow. Okay, from the beginning. Okay, so obviously, members will probably be aware, because I think it was circulated, that there was a Tees Valley Health Summit held last week. And so there were quite a number of high-profile speakers in attendance, including Mark, who's here today, obviously. So Mark, I think, is happy to provide a bit of an update on what he gave as part of the presentation. But it was really a kind of, I suppose, get together from everyone from different organisations across the Tees Valley in terms of health, particularly health inequalities. So Julie Gillen, who's the Chief Executive of North Tees and Hartlepool NHS Foundation Trust, set the scene. She's also the Senior Responsible Officer for Health Inequalities for the North East and North Cumbria ICS. And then Dave Gallagher, who you'll know as Chief Officer or Chief Executive of NHS Tees Valley Clinical Commissioning Group, was also in attendance to provide the update on reducing health inequalities, challenges and opportunities. And he's also been appointed in terms of the North East and North Cumbria ICS as the Executive Director of Place-Based Partnerships. So he'll have responsible for the Central and Tees Valley Delegate, which essentially means he'll have responsibility for the Central and Tees Valley Integrated Care Partnerships. And then Professor Peter Kelly was also there to give an update on health inequalities in the Tees Valley, the good story, key challenges, and what more could be done. So I've tried to condense these all down to one slide per person effectively. So sorry, there's not a lot on there. But in terms of setting the scenes, Julie Gillen was very much that this summit was all about what we're going to do together to provide the bedrock about how we tackle health inequalities in our population. She made reference to the Marmot Review 10 years on, explained that it was the biggest and most compelling report for us, and that it made specific mention of how life expectancy in the North East is dropping. It was emphasised that health inequalities are unfair and unavoidable differences in health across the population between different groups within our society, and they arise because of the conditions in which we are born, grow, live and work. So she also explained, obviously, that in the summer of this year, the integrated care systems are going to come on board in the integrated care boards, and it'll be an opportunity to ensure that the Tees Valley has a common voice in reducing health inequalities, tackling population health proactively and preventing ill health. And there was a real emphasis that our voice needs to be heard. It was also obviously advised the integrated care system in the North East and North Cumbria. It's the biggest population of any ICS in the country, with 3.2 million population and just over 700,000 people in the Tees Valley. And there was very much an emphasis that actions already began in the Tees Valley, and now we need to make sure that from this point onwards, what we got out of that summit was about moving this forward further, faster and at pace. She talked a little bit about, there was also obviously emphasis on about some of the system priorities that have been developed in the 5-year plan for the ICS. A few of the actual targets, I guess, around health, reducing health inequalities were referenced, and the three of those there were obviously picked out as being of the utmost importance: reducing smoke prevalence to 5% or below by 2025. I think Peter Kelly repeatedly emphasised that that is the single biggest thing that we could do to improve health within our population, to raise the average life health expectancy for men and women to 60 years by 2029, because obviously there's a big difference in between what we class as a healthy life expectancy in the Tees Valley and the England average. And again, half the gap in average life expectancy for both men and women between the North East and North Cumbria ICS and the England average by 2029. So obviously there's some more longer term goals by 2025 and 2029. It was also talked about the Tees Valley Integrated Care Partnership, how that all will work. It was very much an emphasis on place, that in terms of Stockton, Middlesbrough, Hartlepool, Darlington, the places will stay very much together. We've also got the health and wellbeing boards, although we only have 4 of those, because obviously we have a South Tees joint health and wellbeing board with Redcar and Cleveland. In terms of the development of the integrated care partnership, we'll have an integrated Tees Valley integrated care partnership, and that will really build on the work of the joint strategic need assessments and the joint health and wellbeing boards that are already in place. It was very much an emphasis on, it's not just about place, but about people, about improving people's health, reducing health inequalities, and bringing everybody together to work collectively on that, including the NHS, the local authorities, third sectors. It was very much, Dave Gallagher talked about the Tees Valley Integrated Care Partnership, and he was very emphatic about it being a collective voice, and about there being a necessity to punch above our weight and ensure as well that we brought in the funding. Peter Kelly gave a very interesting presentation on what actually can be done about health inequalities. He made reference to the Chief Medical Officer's statement in 1939 about, upon the broad minds and vision of our local authorities, the future health of population depends. It was very much emphasised that this is work that needs to be done bottom up, through communities, through local authorities, working with our health sector partners. And that's very much what the health representatives that were there trying to do alongside the local authorities. And one of the examples he gave it started with some really good data. So in the mid-1990s, you'd have a 22 to 25% higher chance of dying from a heart attack on Teesside compared with the England average. By 2010, that gap had virtually been closed, and by 2012, the gap had closed completely. So the burden of people dying early from heart attacks is dramatically reduced. Certainly, you've made reference when people say we can't do squat about health inequalities, we can actually do something about health inequalities, and heart attacks are far more common than they were previously. So it was good to see that things that have been done, but he also talked about some of the real challenges that we have in the area in the Tees Valley. One of the key challenges that he referenced was about the children living in absolute poverty and low-income families, and how these children are going to be our adults in 10 to 15 years' time, who then have a lot of health conditions which they'll have because they've been brought up in poverty, which is a real challenge for us. But in terms of good news, he also emphasised that in terms of giving our children the best start in life and children who achieve a good level of development at the end of reception, it's a critical health indicator as well as a critical educational indicator. And it's evident that good education gives better health and better wellbeing chances. And within the Tees Valley, there are some real green shoots there. Stockton is actually significantly better than the England average at giving children a good start in life, despite being higher than the English average for the number of children living in absolute poverty. So there are differences that we can make through other areas, and not just health. The education that's being provided and the good work that's going on in schools is sort of an evidence of that. Preventable mortality was another key challenge that was mentioned for the Tees Valley. And that's a very brief summary, because obviously there was a lot of information talked about. Thanks, Chair. I think Mark had his own presentation, which I think he's going to talk about as well. Thank you.
Thank you for that. Do we want to go straight on to yours, Mark, or has anybody got any questions for Carolyn? Councillor Halawi?
Yes, thank you, Chair. Yeah, I appreciate all the different attempts that are being made, and the successes that are there in the reduction of health inequalities. But Chair, you cannot get away from the fact that health inequalities, and I'm quoting from a quote that Caroline showed on her slide, health inequalities are unfair and avoidable, and the differences in health across the population between the groups in our society are noticeable. And what we're talking about are have and have-nots in terms of money. When Caroline says, and this is from that conference, challenges for living conditions for children in poverty, they're going to have significantly reduced prospects in their lives because they're living in poverty. Their health conditions are amazingly worrying. When they're brought up in poverty, which impacts upon their education, they are going to have reduced life chances. And that's what inequality is about. And that's what we're talking about, the funding of people in poverty. In fact, the lack of funding in poverty, which is a governmental will. It's their decision to keep some people living in poverty on 0 hours contracts, in poor housing, in poor wages, in a minimum low wage, etc. It is absolutely important that we recognise the poverty in our society, in Middlesbrough, particularly in certain communities. And I'm very closely associated with that. And I feel very passionately the government's making unfair decisions which are impacting on health inequalities and education.
Thank you. Did anybody else want to come in? No? Mark, did you want to come in with?
Yeah, I think part of the reason for the summit, or the main reason for the summit really, was to just get a sort of collective understanding across the system in the Tees Valley, so across local authorities, VCS, and the health service particularly, that this was a shared endeavour. You know, no one agency or organisation or national, you know, like the NHS. The NHS can't resolve health inequalities on its own, and what we talked about in the sort of breakout sessions was around particularly the leadership. How would we go about determining a common purpose, a shared vision, and clarity over for each element who was going to lead, what's the roles around leadership, collaborating or advocating. So everybody can't do everything and everybody can't lead everything. So who's best placed to lead? Who's where should we be collaborating together, and where is our role really just to support what the work of others, and how do we go about collectively prioritizing outcomes, and clarity that the approaches need to be focused at the most appropriate geographic level. So some things can be done across a Tees Valley footprint, and some things will need to be done at a council footprint, and some things will need to be done at an even more local footprint than that. And really just trying to understand. I think one of the issues that we've got when we talk about acting across the system, there isn't really a setting for that. The Health and Wellbeing Board does that within South Tees and then the other local authority areas, but actually doesn't. You know, the individual organisations have primacy over the Health and Wellbeing Board because that's how the governance works in each of those organisations. So how do we act as leaders across the system and get all of the organisations lined up to support the aims of the system? So it was really about trying to, as the start point of a conversation that's got a long history, but actually, particularly whilst the NHS has got a focus and the ICS will have a focus on reducing inequalities, how do we do that working together and amplifying what we're all doing rather than fighting with each other as to who's leading and all that kind of stuff? So it was really around trying to just get that understanding, and particularly with one of the polarities that I talked about with the health services, where we're talking about inequalities in health is different from inequalities in healthcare. Both are important, but in terms of leadership and so on, you could see the NHS critically would be a leader in trying to reduce inequalities in healthcare, and how can they poverty proof their services, ensure that access is I guess better for people that need it more, which isn't necessarily the case across all services, and inequalities in health, which get into the points that Alma was talking about around housing, communities, access to green space, antisocial behaviour, debt, you know, all those sort of issues, which really are the province of the local authorities predominantly, and you know, VCS organisations will be working there as well. So it was really the start of how do we get the system working together. How do we first of all determine what the common purpose is, you know, beyond reducing health inequalities? What does that look like as a vision that all organisations sign up to? So we're all part of that, which would include things like anchor organisations and community wealth building, keeping the spend from all of the organisations, including people like the university, although they weren't at the conference, as local as possible to impact more on local jobs. You know, the Marmot review, the most important point of the Marmot review that Michael Marmot talks about himself is that everybody has a good job that gives a sense of purpose. So the more that we can retain that within the Tees Valley and within South Tees and within Middlesbrough, the more that's going to impact on health inequality. So it's a long-term programme, but the start point is that we get clarity over what it is we're all trying to achieve and what our role is within that, which sounds pretty fundamental, and it is. But if we get that right, then we've got a great platform to progress and reduce inequalities as much as we can within the overall context of whatever national policies exist.
Thank you for that, Mark. I'd just like to say you mentioned green spaces, and I think in Middlesbrough we've got to make sure we keep all our parks, all our play areas for people to walk in, to get out and with children to play, because fresh air and getting outside is so important, and our parks are really important.
Yeah.
Thank you. Anybody else? Right. Thank you so much, everybody, for attending. We seem to have got down to 6 now. I don't know where everybody's gone, but we are still here, and that's the most important thing. So I want to thank you all for your attendance today, and we'll see you. When will the next meeting be? Carolyn? Oh, sorry. I'm so sorry, everybody. I've not given you the OSB update. So I will do that right now. At the OSB meeting, it was the Executive Forward Working Programme was looked at, along with Executive Member Barry Cooper came along to give an update on his portfolio. The Chief Executive gave us an update, Scrutiny Chairs gave us an update, and we also had an update with regarding to the Town Centre from Richard Horniman. And the next meeting for the OSB is the 27th of April. So sorry, everybody, that I forgot that, but it hasn't got this on. I haven't written it on my minutes here. So thank you all. Yes, Alan.
Could I just say before I leave and everybody leaves, a big thank you to Caroline for her presentation today. I found them excellent. Thank you, Caroline.
Thank you, Caroline. Thank you very much, and thanks, Mark. And thank everybody else for attendance. Thank you. Bye.
Everyone, bye-bye.